Good evening, ladies and gentlemen. I am Dr. Ashar Hasan. Today, I'm going to speak on a very important topic, which is urinary tract infection, sometimes difficult to treat. I've done my MBBS from Kolkata National Medical College and my DNB from Kolkata Medical Research Institute. Right now, I am consultant medicine attached with AMRI Hospital, Salt Lake. So first and foremost, let us decide that what is actually a urinary tract infection. When the bacterial growth is more than 1 lakh per microliter of a midstream urine sample, we say it is a symptomatic urinary tract infection. The urinary tract infection can be classified into two kinds depending on its origin. The upper urinary tract infection mainly comprises of the infection of the renal pelvis, which we say the pyelonephritis, and the other, the lower urinary tract infection, comprises of a urethra, bladder and ureter. We have all seen that in today's life, we say that a urinary tract infection is complicated. Now, what is a complicated UTI? Generally, when there is some abnormality seen in the structure and the anatomy of the urinary and the renal genitourinary tract, when there is deficiency or deterioration of renal function, or there is some abatement or lowering of the host defense mechanism. Generally, these are the scenarios where we say there is a complicated UTI. Generally, complicated UTI is also seen in males and in children, especially in the pediatric age group. What are the risk factors when we say that the urinary tract infection has happened? First and foremost, you see that it's very common in sexually active adults, mainly females more than the males because of the lower and the smaller urethral tract. Sometimes we use spermicidal jelly in the diaphragm. That can also be a factor. Pregnancy, as we all know, is a known factor. The deficiency in the host mechanism of fighting germs, and where the impaired immunity, where there is some history of diabetes mellitus, or there is history of steroid intake or immunosuppressive as in cancer chemotherapy, or there can be sometimes an obstruction in the urogenital tract that is called an obstructive uropathy. First and foremost, let us discuss some of the most common organisms which can cause this UTI. The common organisms in almost 70% in our population in our part of the world is an E. coli. Second and third are the Proteus species, the Klebsiella, the Staph saprophyticus, and sometimes even gram-positive Staph aureus can cause infections. But in today's world, where there is rampant use of antibiotics, where there are so many comorbidities, where there are repeated hospitalizations, we have seen that symptomatic fungal urinary tract infection is also coming nowadays very much in our hospital setup, and especially also sometimes in the OPD also. We have to keep all this in our mind. Now, what are the signs and symptoms of any disease? We speak about the signs and symptoms. Generally, if the person have a lower abdominal pain, when there is vomiting, there is fever, there is hectic rise of temperature with chills, there is loin pain, when there is increased urgency and frequency of urine, sometimes hesitancy, all these cluster of factors can be said that a person may have a urinary tract infection. Regarding the findings, we can say that what are the investigations we can do in diagnosing such a thing? First and foremost, I think a urinary dipstick test is very much suggestive and helpful in our scenario. A positive test for nitrite and a WBC count more than 5 per HPF is very much suggestive with the clinical signs and symptoms of a urinary tract infection. What is pyuria? We all see there is a pyuria. Now, pyuria is, we say that when there is more than 20 WBCs per high power field of the urinary sample. One very common scenario we see that there is some condition where we find the WBCs are present in the urine, but the culture is negative. In these we say that this is a condition of sterile pyuria. Now, what are the conditions where we see sterile pyuria? It can be seen in a partially treated UTI. It can be seen very much in TB, genitourinary TB. It can be seen in appendicitis, calculi, bladder neoplasm, papillary necrosis, and sometimes also in polycystic kidney disease. UTI in children should be of very much importance, especially in the young age group. It is more commonly seen in males. They have some anatomical defects, and we should pay utmost heed to such patients because there may be some developmental defects in the urinary tract. We can diagnose such scenarios by the help of an ultrasound. The specific and some very special investigations can be done in the smaller, in the pediatric age group. Mainly you do the urodynamic study in the elderly, and in the younger age group we can go for cystoscopy and also of the CTKUB if warranted. What is a recurring UTI? When you have more than 2 symptomatic urinary tract infections in a year, that is called symptomatic. What is a relapse? When you get infected by 2 different organisms in a span of a few weeks to months, that is called a relapse. In all these scenarios, we have come across that a person comes to you with the signs and symptoms, we have done the investigations, and we are finally proceeding with the treatment. Whom should we treat? As we have discussed earlier, that a complicated UTI mainly seen in males, where there is some structural defect in the tract and anatomical lesion is there in the urinary tract, or there is decreased renal function, where there is an acute kidney injury, when there is impaired host defense, mainly in diabetes or patient who is taking cancer chemotherapy or immunosuppressives. And in today's scenario, where we have seen in the COVID pandemic, we have used in our hospital setup good number of patients who are hypoxic, they're getting high dose of corticosteroids. So these drugs can also impair the host defense mechanism and can lead to devastating UTIs, which can lead to urosepsis with multi-organ failure, sometimes multi-organ dysfunction and septic shock, and ultimately demise of the patient. So you have to be very careful in this scenario. So regarding the treatment aspect, I would like to say that after we do the routine blood tests like CBC and CRP, which will indicate a high TLC, and CRP will be indicative of an infection, a urine RE with dipstick with positive for nitrite and a positive WBC of more than 5 by HPF is very much indicative of an infection. Sometimes in complicated UTIs, we may have to do the cystoscopy and urodynamic study, mainly in the elderly. Thirdly, if we want to start the antibiotics, send the cultures, and according to a local antibiogram of your area and your hospital, we start with a broad spectrum antibiotic which generally works, covering the Enterobacteriaceae, which is mainly comprised of the gram negatives, mainly the E. coli, the Proteus, the Klebsiella. But in certain scenarios, we have seen that there can be infection by gram positive also, like Staph cyprophyticus, Staph aureus, and sometimes, very rarely though, but we do encounter is the fungal UTI, which candida infection is very much common. A budding yeast cells in the RE is a very important factor which we sometimes miss, so you should pay hindrance to it. Budding yeast cells found in urine RE with a patient already on antibiotics and getting bad, his or her clinical condition deteriorating, and his blood parameters, the septic parameters going over the top, it can be suggestive of a fungal UTI. So we should keep that also in mind. Generally, in symptomatic patients, we treat antibiotics. In our part of the world, we generally, in my hospital, we start with the 3rd generation cephalosporin, which is renal friendly. Mainly the cefoperazone sulbactam is very much helpful in this scenario. We start with the patient, we give adequate fluids, we take care of the risk factors, we give him ample nutrition. If there is diabetes, we take a proper glycemic control. So in totality, if we take care of all these things, I think even in the difficult cases in the real life scenario we have taken, because the earlier you act and the harder you hit in the beginning of the infection is very much important to curtail this very important and life-threatening disease sometimes. In elderly who are generally more than 65 years of age, and if they are asymptomatic, even pyuria may not be treated, because we have seen in a clinical experience that in this scenario maybe the antibiotics doesn't help that much, but rather it causes side effects like increased rashes or some GI intolerance and GI disturbances. So looking into the overall scenario, UTI is a common problem. It is faced by each and every one of us in the OPD and IPD basis. Plus sometimes they can be complicated by decreased renal function, by other comorbidities like having an AKI or having a cirrhotic patient having a kidney disease with an UTI. It can be multi-organ failure. So in this scenario, we have to be very much vigilant about the local antibiogram, hit hard the patient with IV fluids and proper antibiotics broad spectrum, wait for the cultures, and if we see that the cultures are susceptible to the new organism, we can also de-escalate the antibiotics, looking into the patient's overall status and his or her hemodynamic stability. So with this, I come to the last part of my say, I would just like to say that UTI is common. It is faced by our physicians, by urologists, by surgeons, by gynae. Even in pregnancy, we have seen it's a big risk factor. So all my gynecological friends, they should be aware that this is a disease which can cause damage to the fetus, also can cause sometimes premature delivery, sometimes can cause IUFD also if there is gross infection. So we must be very vigilant and act at first and hit hard this pathogenic organism. So with that, I am coming to the end of this my little talk on UTI. I hope it was helpful. It will help us people to act in a proper way to curtail this disease, because it is always going to be there in the future, and it is one of the most commonest infections where patients get admitted in a hospital for it to be treated. So thank you very much. Thank you all those listeners that you have given a peaceful and patientful ear to what I've said. And I think the most important thing is we learn from our own patients. They are the best teachers, and try to implement this knowledge we have gained in the future so that we can have a better outcome in this sometimes dreaded disease. Thank you.